Every health system leader has executive management challenges facing their organization. This show supports leaders in addressing those challenges with cutting-edge information, leading strategies, and sharing best practices. Listen in and gain keen insight as industry leaders share their stories. The Baldrige Foundation welcomes you to Leader Dialogue Radio.
Welcome, everybody, to another episode of Leader Dialogue, brought to you by the Malcolm Baldrige Foundation and our sponsor, About Healthcare. I'm Dr. Chuck Peck, and as always, I'm honored to be here with some friends of mine, Ben Sawyer and Darren Versillo. Darren and Ben are executives at About Healthcare. It's good to be back with you guys again, as always, and I'm really excited about today's podcast. The topic is Achieving Systemness, Analyzing Gaps and Opportunities in Today's Environment. And I'm particularly excited because of our special guest today, who I've gotten to know over the last 4 to 5 months very well, and that's Dr. Conrad Vial. Dr. Vial is Sutter Health's Senior Vice President and Chief Clinical Officer. He's a practicing cardiothoracic surgeon who has held various leadership roles in multi-specialty medical group practice and integrated healthcare delivery. Dr. Vial received his bachelor's degree and medical doctorate from Stanford. He earned a Master of Philosophy at Cambridge University in England, while also completing a postdoc fellowship in transplant immunology. He conducted his general surgical and cardiothoracic surgical training at Stanford University Medical Center, and he's board certified in both general surgery and cardiothoracic surgery. So, Conrad, it's great to have you here, and we really appreciate you taking the time to talk with us today.
Chuck, I appreciate being invited. It's always good to be amongst friends and to discuss what I think we'll all agree are pretty important issues in this time or any time.
For sure, absolutely. So let me start off with a question, Conrad, and then we can see where this goes. But, as the nation's health systems emerge from COVID, many gaps and opportunities for improving care are becoming evident. I know I have clients who are thinking that they're just going to go back to the way it was before, which I would call at this point the old normal. But we also work with folks like yourself who believe that the old normal is just not going to cut it, and that we need to be looking at doing things differently and moving into what I guess I'd call a new normal. So I'm curious, what are systems like Sutter Health, a very, very large health system in California that I'm sure everybody on the podcast is aware of? What are you doing to identify some of these opportunities? What gaps and opportunities in care have you already identified? And do you have examples of some new care models that you're either thinking about or already implementing?
Yeah, you've kind of captured the moment, I think, in many ways in that question, Chuck. To take your question sort of in order, I would say that the first thing that we, like I hope most healthcare systems and the system writ large, system with a capital S, I hope what we're doing is really adjusting our perceptions, our projections, and our attitudes around where we are in terms of that spectrum of old normal versus new normal that you just laid out. I think the pandemic, and I'm quite aware I'm not the only one who has observed this. The pandemic has done a few things that perhaps are unique in terms of impacting or changing perceptions around healthcare. But I think for the most part, what the pandemic has done has been a catalyst. It's been an accelerant. It's been something that has forced us to take on board and start to implement around ideas that I think existed for good reasons before the pandemic. I think from the perspective of integrated healthcare delivery systems, the themes that I think the pandemic has really forced us to confront and that I hope we'll continue to confront and drive towards positive change around are themes like, what is the difference between size and scale? What is the difference between assets defined in physical terms and human factors that underlie resilience and truly scalable compassion? And what is the difference between where value is created in healthcare in the new normal versus the old normal. What I mean by that is I think in many respects we have looked at healthcare systems as delivering value primarily through their physical assets, their infrastructure, their venues of care delivery, their tools and technologies, and certainly those continue to be important. But I think what I'm seeing in the pandemic is a recontextualization of the importance of those factors. In many ways, those are secondary for the good of patients and their caregiving teams. I think the new normal will be one in which we acknowledge that really our ability to raise insight, our ability to make insight be actionable and meaningful in the pursuit of sustaining well-being where people are well and restoring well-being where people are ill is really the competitive differentiator, and for good reason. I think we ought to actually celebrate that. It's going to be a bumpy transition. It already has been. But I think getting away from this idea that your physical assets define your ability to generate value and talking more in terms of those physical assets and frankly intangible assets as tools and merely tools in the ability to raise actionable insight that pertains to the well-being of either individuals or populations, that's where we need to be going. And that's where the pandemic is pushing us. And that is not something that we shouldn't be not only cognizant of, but frankly celebrating.
Yeah, those are some great thoughts, Conrad. And actually, it takes me to another question that I was thinking about as you were talking. I think all of us on the podcast here agree with your analysis of physical or tangible assets versus a lot of intangible assets that maybe we haven't thought much about over the years, way prior to COVID, as you were talking about. And, one of the things I was wondering about is whether you're looking at, as an example of this, different kinds of partnerships with physicians or vendors to enhance the effectiveness of your care models and the efficiency of your care models. In other words, instead of using all the available capital that you may have to build more buildings, so to speak, whether you see much more value in things like partnerships, maybe some things that we haven't done before, that we weren't innovative enough in healthcare to think of before, things that are more intangible in that regard that bring much more value to the people who are taking care of us, the doctors, nurses, et cetera, but also to the patients we're caring for.
Yeah, that's an important theme. To unpack it a little bit, I think it's interesting to think a little bit about the journey of tech versus healthcare. And I don't mean to make the comparison be too strict or too close a one, because obviously there are very, very important differences. But the journey of tech has been one of moving from products to systems to solutions to platforms. And when you think about the journey of healthcare, both industry development and the craft, as well as the science and art, if you will, we're still sort of celebrating when we can put together, quote, systems instead of mere products. And I don't think the healthcare analogs necessarily to solutions and platforms have been built out and coordinated or integrated in the way that they could have. And I think that's a real opportunity for us. It's been an opportunity for a while, but it's one we really can't turn our back on now because of, again, what I think the pandemic has brought to us. You hear a lot, appropriately, I think. We've been hearing a lot about it, certainly since 2011, about the transition or the pivot from so-called volume to value. I'd like to suggest that we ought to reframe that much more along the lines of the pivot from, quote, production or the analogs of production to performance. Performance is a bigger category than production. It involves production, but it involves production set up against categories that I think are even more compelling and ultimately more important for the end user and the consumer of whatever we're offering. And in that regard, I think that we need to recognize that the economics of healthcare are such that fee-for-service is not going to go away anytime soon, that fee-for-risk will increasingly become important, and that transition is going to be or continue to be a more protracted and a messier one than any of us would like, but that's reality. I think talking about value as somehow only assignable or attributable to fee-for-risk arrangements misunderstands the point. I think we are going to, because of the economic realities that are currently with us and going to continue to be with us, pandemic or no pandemic, we're going to continue to need to recognize value as something that we create irrespective of the avenue of revenue intake, irrespective of the particular book or sub-book of business that we look at, and frankly, irrespective of the clinical channels of care delivery. Because without that, I don't think we will make the transition as gracefully as we otherwise could. From our perspective, that means trying to, through population healthcare capabilities and related toolkits, make it actionable and satisfying and accessible to practicing clinicians, to clinical decision makers, to practice with a value-driven mindset, irrespective of whether they happen to be taking care of patients in a fee-for-service arrangement or a fee-for-risk arrangement. That means locating the sensitivity to performance factors and not just production factors as close to the practicing clinician as you possibly can. And every system and every culture will have a different set of guardrails from a regulatory perspective and an industry perspective, as well as from a clinical strategic perspective, around how to do that in their particular marketplaces and in their particular system. But that general theme, I think, is and needs to be one that we're all focused on.
Darren, I know that you probably have a lot of questions for Conrad. I think that if one looked at About Healthcare, didn't know anything about it, they would probably classify it as an IT company, so to speak. And I know that you must have some thoughts about what Conrad just talked about in terms of that it's much more than that. So please go ahead.
No, certainly, and this is my first time meeting Conrad on this podcast, so it's great to make your acquaintance. We've actually
likewise.
Yes, with About Healthcare, formerly CentralLogic, we've had a history of working with Sutter for many years. You mentioned 2011. I think that's roughly when we started working with your transfer centers across the organization. And Sutter's a broad and diverse system with its roots and mergers and many different cultures bringing together across the north of California there. And it's been wonderful to watch that ongoing transition through the years that we've done work there, and seeing those cultures coming together. We've talked about this idea of systemness, and I wonder if you'd comment, Conrad, as to the ongoing journey that Sutter has had to create systemness across those different cultures and those different organizations that were brought together, and maybe from the perspective of physician culture, as well as with your work in administration, how the different business aspects of Sutter come together and support each other, as opposed to working in silos. How do you create? What's the journey to create that system? And how has the pandemic also catalyzed, to use your word, catalyzed that ongoing transition?
Yeah, you point to a destination that, I don't want to speak for other systems around the country. You point to a noble destination, and it is one that we are still working our way towards. I can't say that we're there. We have to be honest, and we have to be humble that this is it's a difficult and complex endeavor, healthcare, I mean. Mm-hmm. And we are unfolding our efforts in trying to take care of communities under a not-for-profit mission in a pretty challenging environment. Northern California, in our case, almost 3.5 million patients living in communities that are extremely diverse, or extremely complex in terms of their histories and ongoing dynamics. A singular system that is an open system from a physician perspective and also from a patient perspective. We take care of more fee-for-service Medicare and Medi-Cal patients. So within that, you can think of the elderly and the indigent than any other system in Northern California. And yet we're doing so in an environment that is replete with challenges from an economic perspective, from a regulatory perspective. Cost pressures are intense everywhere. They are especially intense in the environment in which we're doing business. So,
and not a non-competitive area either. I mean, you have
no, certainly is not. I mean, I think Northern Californians are blessed with lots of choices, extending from not-for-profit community care up through, major academic missions that are also involved in healthcare delivery. From a Sutter perspective, I'll tell you, you're quite right to point out the fact that Sutter's, healthcare roots go back over 100 years in Northern California. But it's 100 years in different places, in Sacramento and San Francisco and lots of places in between. And the Sutter that we know today has been a Sutter that has been built over time through a series of not just economic and structural mergers, but very, very noble attempts at cultural mergers. And this is something that is important to bear in mind. You mentioned physicians. I want to say that physicians are critical partners, but in many regards, I see them also as customers. Physicians have choices, whether they be an independent practice or they be in foundational line group practice. They have choices as to what system or what systems they can align with. And so the importance that I think Sutter needs to place on recognizing that our product is something that we deliver through a medium, and it's a medium that is fundamentally based in human relationships. And those human relationships are between caregiving teams led by physicians and patients and their families and the communities they come out of.
Absolutely.
And we have to be very, very mindful of what everybody's role is so that we can harmonize those roles. If physicians are delivering care to patients through those relationships, then Sutter's role is to help to enable those relationships to flourish, to help that care to be delivered in a way that really allows us to reach a level of scaled compassion, if I could use that term, and satisfaction that is an improvement, a net improvement over what healthcare has been. And again, I get back to the themes of looking for us to align around and create incentive alignment around performing together rather than merely producing together. So I think, what you're pointing to is the core cultural challenge, at least for our system and in our part of the world. But here's the good news on this. And I'll maybe end my response to your question on this point. We could be worried or scratch our heads and be paralyzed by angst around, the enormity of the challenge and the complexity of practicing in an environment which is what I described Northern California as. On the other hand, we could also see this as an immense opportunity for us to take on board really caring for a population that, although it's, let's call it 3.5 million, at least from a Sutter footprint perspective, those 3.5 million people look and feel a lot like the rest of the United States populace. The level of complexity culturally, the level of disparities in income and access, the rural versus urban, choose any spectrum of healthcare demographics or healthcare clinical and business strategy, and you will find that what Sutter is facing and what Sutter is taking on, it is something that has potential to really speak to some solution building for the rest of the nation system, because that's how complex and diverse our environment is.
Ben, I know you're thinking about a lot of things, so please go ahead.
Yeah, so my question kind of comes through the lens of performance improvement and the Baldrige, Conrad. I was really intrigued with what you were talking about with human factor resilience and focusing on compassion and really the performance factors as close to the provider-patient interface as possible. Kind of that's where the moment of truth is. And again, being a process guy, a couple of the questions I have are, what are the implications for systems when you start there and work backwards? Like you said, you're looking at existing structures as just really assets, right? And they need to be reconformed essentially to fulfilling the value that you're delivering to customers across a much broader, clinical structure than we were pre-COVID, right, which was largely acute care centric. So there are three things that came to mind, and I'm just wondering if you could comment on those. One is the orientation of leaders to more of a servant leader mentality, right? Almost an inverted pyramid where the patient and consumer is at the top, and those that are driving the moments of truth are the focus of attention, as opposed to driving mandates down from senior leadership. Sure. So that was number one. The second one is something that we're hearing in the tech side, which is composable solutions. In other words, instead of having rigid structural solutions that are, clinical documentation and billing and so forth, that really the technology has to adapt to become composable to what the organization is trying to accomplish. And then the third that comes to mind is this whole notion of sort of access and orchestration, right? In other words, if patients are coming into Sutter from whatever portal, how do you make sure they get to the right place? Like if it's a cardiac patient, do they actually need to be admitted, or could they see someone in their office or a service line cath lab in a lower cost, higher quality, better experience type of environment? And how do you know what those assets are, and then be able to orchestrate that to the best effect of the patient and consumer, including their follow-up on their pop health needs, should they have, social determinant of health kind of issues. So I know that's a lot, but maybe just to summarize, as you're thinking through that human factor, provider, consumer, moment of truth thing, and starting with performance and working backwards, what are your thoughts on kind of those three things: the shift in leadership, the servant leadership, the shift from highly structured IT to more composable solutions, and the notion of sort of real-time access and orchestration of demand to capacity within the enterprise?
You're right. There is a lot there. And I think in follow-up to whatever themes I invoke now, I'm happy to go deeper as you all wish. But I think you've, as has been true of this entire conversation, you've touched on some really resonant themes. Let me say this: one of the legacies, one of the blessings, if you can use that term, right? One of the blessings of the pandemic has been to sort of open up the hood and let us look at what the real engine that drives satisfying, effective healthcare looks like. And that engine is an engine that remains profoundly human, despite the fact that there is an absolute opportunity as well as a need for us to take digital tool development, which is so much a part of the cultural moment that we've been living through. And I'm in Northern California and come from the Bay Area. So the Silicon Valley zeitgeist is not one that you can escape here very easily. I don't think you can escape it anywhere now. But the point is, how do you utilize digital tool development and application to actually improve the humanization of healthcare service and delivery, rather than detract from it, which is, we're wrestling with this societally and culturally in a lot of other areas. But, healthcare and education are the two that I have sort of that win my heart and soul every day. And so what I would say is this: you invoked some principles around process improvement, and I would say, whether you're talking, looking at the problems through the lens of the lean methodologies, or you're looking at it through the lens of human-centric design, or you're looking at it through the lens of the scientific method. The fact of the matter is there's a convergence of viewpoints there coming from all of those perspectives, because all of those perspectives are fundamentally focused on improvement science and improvement art. And it is both. Improvement is a craft. And I think what all of those disciplines, and there are sub-disciplines within each of those, what they all share in common is a recognition that you've got to, whether you're going to use the word Gemba or you're going to use the word, you're going to invoke sort of the use of the human agency that's involved in any collective endeavor, or you're going to focus on it from the perspective of getting meaningful data and interpretations thereof. The fact of the matter is you've got to be out in the front line. You've got to be in the mess. You can't be looking at it from either an ivory tower or, frankly, a corporate boardroom perspective. And so one of the key elements in how we move from old normal to new normal, I hope, will be a more thoughtful reflection and a more vibrant conversation that we can collectively have around what is it about healthcare that needs to be run, if you will, from a central perspective, if we're talking about systems, because there is compelling value and accessible, meaningful scale by running it that way. Mm-hmm. And how does that need to interplay with what parts of healthcare need to be run on a more local and customized basis? Right. Because really the highest level of not production, but performance, getting back to that theme, you'll notice I'm pretty obsessively devoted to it, because that level of performance really requires something that's a bit more bespoke. So think about, for example, regionalization to drive to more effective volume performance relationships in rarefied tertiary and quaternary skills sets and subspecialty or specialty care versus primary care. Primary care in a very much disrupted form, meaning primary care that is still humanistic, local, and bespoke, but team-based, and often multidisciplinary team-based. To recognize that our physicians, we talk a lot about burnout. We talk about a lot about the need to do things for burnout. And then on a parallel channel, we often talk about how we need to be patient-centric. I think the key here is that lots and lots and lots of sources of credible data show us that the two are so fundamentally and inextricably intertwined that we really ought to be focusing on not just doctors and not just patients, but frankly, the relationship between the two. It's this relationship centricity that I think we need to call for. It's not about me or you, it's about the us principle in healthcare. Frankly, I think the same is true for education. So my sense around this is that if you take something like digital tool development and application, or you take something about, IS or IT, that is the same conversation for me. Mm-hmm. We keep thinking about digital or IT from a clinical care delivery and a business perspective as sort of off on their own island, as though we were all inhabitants of an island archipelago society. And that's just not true. I mean, IT and digital are not sort of adjuncts to care. They are often the care, or they're certainly so close to the care that they need to be accessible and show up meaningfully for both caregivers and care receivers in the local environment. Yes, there's all kinds of aspects of the infrastructure management and innovation efforts that need to be run to scale and that therefore have to map to a centrally driven vision and strategic set of formulations. But it has to be less dichotomous than it is right now. And again, healthcare is late to this conversation in many respects. I remember a 3 months ago reading an opinion piece put in by an IT leader in tech business sector, talking about how I think he was being hyperbolic to make the point we should abolish the IT department. I don't think he meant we need to abolish the IT department. What he meant is we need to have a more distributed model that exists or coexists in a central scale planning effort model. So it looks a lot more like an ecosystem with niches being subserved in the way that they need to be, rather than, again, to use your terminology, a top-down approach. And I think that lean mindset and methodology-based techniques, human-centric design techniques, and scientific team health system science approaches will all need to be harmonized in order to drive improvement in that direction. But that's really the direction we've got to go.
So Conrad, this has been a fascinating conversation, as I knew it would. And, we'll be having more conversations around these themes. Hopefully you'll be able to potentially join us again. I think the central focus of humanism and thinking about why we're really doing all this work and how all these different pieces, parts integrate one to another to, at the end of the day, try to help patients and get rid of suffering and all the things that I think you've been talking about are really important topics. So, thank you very much for joining us today. It's been a great conversation, and hopefully we'll get a chance to talk again soon. Thanks again, everybody, for listening, and we'll look forward to seeing you again at the next podcast.